Sunday marks the 10th anniversary of September 11th. We all remember that day, especially here at the school. The school year just beginning, and many of us sitting with students as we got the screens down and we watched things unfold. And it was a day that changed everything. We all remember where we were that day. Many of you grew up in a different time as a result of that, much as when we were young, we remember where we were the day of the President Kennedy assassination. We will always remember that day. All right. And I think it's good for us to reflect a little bit today. We recall where we were. We heard about the World Trade Center towers, then the plane in Washington, D.C. and the Pentagon, the fourth plane in Shanksville, Pennsylvania, and almost 3,000 people who were killed that day, many firefighters and first responders. It changed the way not only our nation but the world thought about things, and those events challenged our sense of security. And it was also a call to action for the public health community. Those events of September 11th, particularly the following events with the anthrax attacks soon afterward in October of that year, brought a new focus on public health. And I know many students that I've met in the past 10 years were really drawn to public health, learned about public health as a result of that. Few people realized that day as we grounded the aircraft, as we made a desperate effort to find out where our faculty were all around the world, how many may have been stranded in airplanes, and many were. There were 2 non-military aircraft in the air. One Air Force One, and one, a cargo plane coming up from CDC with the public health team responding. We were there in the background, but public health has a major role in preparedness, and we're going to talk about that today. So as we think about that, I would like to think about the lessons we have learned. Many of us have also been involved in subsequent disasters. A lot of positive things happened because we focused our attention on the public health response. And so some of us were involved in Katrina. We've taken that knowledge forward in how we plan for emergency medicine. We've recognized the deep impacts on community mental health that these events have. And these are some of the topics that we'll explore today. Even in the current rains, my mother would say the angels are crying. Man, they've been crying for too many days. As we begin planning, we've helped to shape the future of public health, and you'll hear about that today. But first, I would like to perhaps have a couple of minutes of reflection and play a video that the school has put together, reflecting on that day and the events afterwards. So if we could have the video now.
The morning of September 11th was an amazing day. It was the perfect temperature.
We also all remember how blue the sky was. What a wonderful September day it was.
You were able to see the towers from that far north. I was commuting in from Long Island.
I was driving to Inova Fairfax Hospital, which is about 10 miles outside of the Pentagon.
I was traveling on a Swiss Air flight from Zurich, Switzerland, to Washington, D.C.
My son Olaf and I were in Prague.
I was on my way to work, and when I walked in the door, everyone was crowded around the television set in my office.
Anyway, I remember turning away and someone screaming that one of the building went down.
As I called home, my son, my strong 18-year-old son, is crying to me saying, "Dad, the trade center's fallen down. I'm watching it on TV."
One of the drivers had turned on the automobile radio, and we heard the announcement of the destruction of the 2 World Trade Towers.
There's been a terrorist attack on the United States.
We were on call for casualties from the Pentagon, and we waited all day. Nobody came. Nobody came because you either survived or you didn't. There was nothing in between.
There was a lot of anticipation for all the survivors. forget about it. And there are no survivors for this.
The only part of the hospital that in fact was doing anything was the call center.
How can a group of people do this sort of action to another group of people?
The site itself was an extremely moving place, obviously. They would find a body, they would stop work, and they would kind of create a procession with a flag-covered body to bring it out.
I remember so distinctly giving my passport to the customs official. He asked me had I been out of the country the whole time, and when I responded yes, he hugged me and said, "Welcome home."
It changed the focus of public health. It added a new focus. And so the whole issue about preparedness and how we coordinate response and work with first responders, how we educate communities, all that came as a result of 9/11.
Before we begin today's program, I'd like to just take a moment of silence now to reflect on how those events affected so many of us and so many people. Okay. So one thing about public health, folks, I always say that, much like Starman said in a movie, the line stuck in my head and it describes public health perfectly. We are really at our best when things are at their worst. And that's how the response was at the school. Immediately we began to ask, what can we do? How can we help? How can we play a role? Some of us felt so detached, having been on the front lines before, and how can academia pull together? How can we train the next generation? How can we get our resources together to help? And that's what you're going to hear about today. That incredible optimism, that spirit, that while the whole world was questioning and many were pointing fingers, we came together as a school with such a diverse population. And our major goal was to make public health better and to be able to serve and be better prepared. So we're going to hear about that today. And let me give you a little bit about how we're going to do this. We have three wonderful speakers who are real leaders in preparedness. And they're going to present, and then we're going to wrap up with a panel discussion. We'll have plenty of time for questions. And if you're watching online, you can submit questions on Twitter with the hashtag #JHSPH911. So those of you on the internet, again, welcome. And now I'd like to introduce our first speaker. Our first speaker is Dr. John Links. He's a medical physicist and currently professor and deputy chair of the Department of Environmental Health Sciences here at the school, with joint appointments in radiology and emergency medicine. John, perhaps as much as any faculty member in the school, really rose to the call to bring his expertise to help the city and the nation, really, in working on preparedness. He now directs our public health preparedness programs here at the school and is very involved in training on the front lines of public health. He's an advisor to Baltimore City's terrorism and pandemic influenza planning efforts and works with the health and fire and police department and the first responders. Please welcome Dr. John Links.
Good afternoon, everyone. I must admit it's with pretty mixed emotions that I stand before you. On the one hand, 9/11 was a horrible tragedy. On the other hand, I literally wouldn't be standing before you without 9/11. Before 9/11, I had never even really heard of public health preparedness. The field existed before 9/11, but it did not occupy a prominent role in public health practice. Obviously, since 9/11, that situation has very much changed. So before 9/11, most of my research was in medical imaging and in environmental health sciences. After 9/11, as Tom indicated, I started working with the city and with the state in particular, and what started out as some technical assistance grew into a whole new career for me, and I now spend the vast majority of my professional efforts working in public health preparedness. And for me, it's the most stimulating and the most fulfilling work I've done in my whole career. So for me personally, in a very odd and somewhat painful sort of way, I've benefited from 9/11, hence the mixed emotions I always carry with me as I do my work. What I'd like to do in the next few minutes is talk about some of the work we're doing here at the school. And I've chosen to talk about the work here at the school as a way of illustrating what's going on more broadly in public health as a result of 9/11 and the real emergence and prominence of public health preparedness in the practice community. So to begin with, it's really only after 9/11 that we in public health have started thinking very seriously about emergency preparedness and, in fact, about an emergency preparedness system. That is, to think about the ways in which we in public health interact with other elements of public health, healthcare, public safety, and so on. And in 2002, the Institute of Medicine created this diagram with governmental public health at its center, but with surrounding spheres that cover the gamut of other elements and components of a full public health emergency preparedness system. And so one of the key ways in which public health practice has changed since 9/11 is for public health to think a lot more holistically and a lot more integratively about its interactions with other elements of government, non-government, private, community, and so on in carrying out its mission and, in fact, in performing public health practice. So before 9/11, certainly in terms of public health preparedness, there was not a recognition of the need to fully interdigitate in a practice sense with all these other elements of what we now understand to be the full system in which public health needs to operate. Now, obviously, if I were a firefighter talking to a public safety audience, the green would be public safety, right? But public health would then be one of the bubbles around it. So depending on how you're thinking about things, the point is that we in public health have reached out to all these other components, and as a result, all the other components now recognize public health as a key partner in emergency management practice. The second thing I'd like to mention is that when we started our work in preparedness with Baltimore City and with the state, there wasn't a lot of research on what it means to be prepared, particularly from a public health perspective. And one of the things we've been able to do is to develop a framework for thinking about preparedness that then triggers changes in practice and how you think about, in a health department, for example, being prepared not only for the standard suite of emergencies, but for crises of any kind. The paradigm we chose to use is based on the common phrase, ready, willing, and able. And when we struck upon this phrase as maybe being a nice way of framing preparedness, we thought, oh, surely lots of people have published on this already. And it turns out no one had. So we were able to adopt this common phrase for our own use and publish on it. The way this concept of ready, willing, and able changes practice is as follows. Most people, when they think about preparedness in a professional sense, focus on able or ability. That is what Webster's would say is having sufficient knowledge, skill, or ability. And in fact, most efforts in public health preparedness at the local, state, and federal levels to get communities prepared focused on ability. So a large emphasis, for example, on training. We were part of that effort. And as we were delivering trainings around the country, it became obvious to us that the public health, public safety, and other professionals involved in first response, that whole workforce that really represents the public health emergency preparedness system might have been trained, so they might have had the ability, but there were other necessary ingredients to a quality response that were missing. And as we started investigating these other ingredients, one of the first that we hit upon was willingness, which you can think of as an affective component to complement the cognitive component of ability. And Webster's calls willing inclined or favorably disposed in mind. And so in a few moments, I'm going to talk a little bit more about our studies on willingness to respond as opposed to ability to respond. But the point here is thinking more multidimensionally about what it takes to do preparedness is a surrogate for the larger issue of what it takes to do public health practice, because we could go from disaster preparedness to any other endeavor in public health practice, and I submit these same components would be required in order to deliver quality public health services. So if people have the ability and if they're willing, does that now set the stage for a quality response? And it turns out no, there's one other set of ingredients, and those have to do with being ready, which Webster's defines as poised to respond. So what we mean by that is the right infrastructure, the right resources, the right systems, including policies and procedures, and so on. And it's really only when you pay attention to all three domains, ready, willing, and able, that you can ensure a quality response. And our thinking around public health practice in terms of preparedness has changed as a result of thinking in this way, and as I've indicated, it's also then had a spillover effect to other areas of public health practice. So to just flesh this out a little bit more, ability is the actual operational capability, its knowledge, its competency, its proficiency. It's typically assessed through observation. It depends on a combination of innate aptitudes and traits, learned and modifiable capabilities, for example, modifiable via training. It's primarily cognitive and behavioral in its dimensions, and it's the usual target of training activities. And if you think about public health practice, well beyond preparedness, training's always been a big part of public health practice and a key way to enhance public health practice. What we're suggesting is that in addition to focusing on ability, you need to focus on these other two domains, willingness and readiness. So willingness, as I've indicated, means inclined or favorably disposed in mind. It depends on attitudes, beliefs, and perceptions. Depends on motivation and confidence, trusted relationships, and so on. So it's primarily emotional or affective in its nature. And then ready means possessing the necessary human and material resources, infrastructure, and processes. What in emergency management is often called staff structures and stuff. Examples at the individual level might be having water, food, flashlight preparedness plans, you know, all the stuff you guys implemented over the last couple of weeks, right? And at an agency level, it might mean things like having a national incident management system compliant incident command system, emergency operations plans, continuity of operations plans, and so on. Let me turn for a moment about what's happened at the school with respect to preparedness and then show you just several results of our activities. It was after 9/11, as I've indicated, that public health preparedness really emerged as a discipline within public health. And Bob Lawrence, who was Associate Dean at the time, put in a proposal to the CDC for an academic Center for Public Health Preparedness, which was to be a one-year training center to train the public health workforce in weapons of mass destruction and terrorism. After a year, Bob was able to get a one-year renewal of that project. CDC then issued a request for proposals for a new program At the time, I was working heavily with Baltimore City on weapons of mass destruction and terrorism preparedness. And so we put in for this new program. We're lucky enough to get it in September of '04. And that program, which focused primarily on training and technical assistance, was with us for 6 years. At the same time, Lynn Goldman, Tom Burke, and I developed a preparedness certificate program, and we launched what ended up being a small series of courses here at the school around preparedness. The courses remain, and the preparedness certificate program remains with Thomas, the director. Around the same time, we were able to get a no-cost extension of the one-year center that Bob had started, so I had 2 centers going in preparedness. And then in October of '08, CDC had made the decision that there was a real lack of evidence on which to base decision-making in public health preparedness, and so issued a request for proposals for a research center that would complement the training center, and we were lucky enough to get that as well. And then in October of last year, we were lucky enough to get yet another center, this one focusing on curriculum development and training of the public health workforce in a very comprehensive way, rather than in a specialty training by specialty training way. So we've had 4 centers in preparedness here at the school since 9/11. It goes without saying, it changed some of our professional lives quite profoundly in terms of what we work on. To give you a taste of some of our activities, this was one of our earliest training products. It's called the Roadmap to Preparedness. It's a training tool that's used at the organization level, meaning every single employee of a local health department receives the training. And in public health, if we think beyond preparedness, if we think more broadly about public health practice, the idea of everyone in a health department having at least awareness level training around an important public health issue is something where preparedness has made inroads in ways that other important public health issues haven't as much, and I think it serves as a model moving forward. In our case, the Roadmap to Preparedness takes a game format. It's based on articulated preparedness competencies. We either deliver the training ourselves or train local trainers who deliver it, now all over the country. And it creates a common foundation of knowledge, and it builds capacity in times of emergency or disaster. Another product for which we're well known, and one in which George Everly, my colleague, has played a key role, is our version of psychological first aid, which we call RAPID. That's an acronym for the 5 core elements of the way we deliver psychological first aid. You'll see a recurring theme in much of our work as a focus on mental and behavioral health issues in disasters, because that's an area that has been understudied and underserved quite dramatically. I'll mention parenthetically that, in my opinion, mental health issues are traditionally underserved in public health, and in disasters it's really no different. So over the 6 years in which the Center for Public Health Preparedness was alive, we were able to reach over 60,000 trainees in a variety of activities, some delivered face-to-face, some delivered online. And all of our online trainings from the center remain alive on the school's website and are freely available to anyone throughout the world. I mentioned a moment ago that our latest training-related center focuses on comprehensive training. It's based on a new competency map developed by CDC and the Association of Schools of Public Health, which I show here. And what we're doing is developing a specific curriculum to be delivered in a combination of face-to-face and online venues that will touch each of these 18 competencies and their associated knowledge, skills, and attitudes. I want to shift now to talk about a model that we use that underpins a lot of our research. It's called the Extended Parallel Process Model. It's a model that's maybe familiar to those of you who deal with health or risk communication. It's used here at the school in those contexts, but we've now adopted it for public health preparedness uses. And it basically says if you want someone to change their behavior and you're doing so by delivering a message, the message needs to have two key components. A component that addresses the receiver's perception of threat and a component that addresses the receiver's perceived efficacy. So if you cannot convince a message receiver that there's a threat they should be concerned about, they're going to disregard the threat and reject the message. If you can convince them that there's a threat they ought to be concerned about, but you cannot convince them there's anything anyone, and especially they, can do about that threat, instead of controlling the threat, they're going to control the fear that you're convincing them there was a threat, but not that they could do anything about it, triggered, and again, they reject the message. On the other hand, if you can convince someone that there's a threat and there's something they can do about it, then they control the danger and the message is accepted. Now, this model has been used for things like family planning, HIV/AIDS, smoking, seat belts, motorcycle helmets, etc. It comes out of the fear appeal literature for risk and health communication. To us, we thought this model could also be applied to the public in terms of, for example, having a preparedness kit, the thing I talked about a few moments ago that all of you used during the past 2 weeks. But we also wondered whether or not it would have relevance for first responders in terms of their own willingness to respond. And so we launched a series of studies, the first here in Maryland with 3 county health departments way back in 2005 that stirred quite a bit of controversy at the time, when we showed that half of the workers in those local health departments were not willing to respond to a variety of emergencies. And that was because at the time, even after 9/11, public health professionals did not think of themselves, of ourselves, as 24/7 first responders. We've now had the opportunity to do studies in over 100 health departments throughout the country, thousands of health department employees participating in the surveys, and what we found is that willingness to respond is much better than it was in the early days after 9/11 when we didn't think of ourselves as first responders. But there are still significant gaps. And those gaps, not surprisingly, are related to the type of event. So for us, we think we understand weather events. We certainly think we understand pan flu. To a certain extent, we even think we understand anthrax, but we don't think we understand dirty bombs, and it makes us less willing as professionals to respond to that sort of event. So if we're required by an agency to respond to a dirty bomb event, 84% of public health workers surveyed say yes, they'll respond. But if asked but not required, on the average, only 75% are willing. Now, of importance, we can use our extended parallel process model, this notion of perception of threat and perception of efficacy, to try to understand willingness to respond. And what we find is when compared to public health workers who end up characterizing themselves as not really perceiving the threat and certainly not perceiving that there's an efficacious response to the threat, that if you perceive the threat, perceive the efficacy of response, and especially if you perceive both the threat and the efficacy of the response and your own self-efficacy, what we call a concerned and confident public health worker, the odds of being willing to report for these 4 types of disasters goes up very, very significantly. These are very large odds ratios compared to workers' willingness when the workers think there's no threat and no efficacious response. So we're now studying an intervention which we call FIT, Public Health Infrastructure Training, that seeks to enhance willingness to respond. And in our pilot studies, comparing 6 clusters of health departments that didn't get the intervention with 6 clusters of health departments that did, you can see that in the control clusters of interest, actually willingness has gone down over the intervention period, but it's significantly increased in the intervention clusters. And I particularly draw your attention to the dirty bomb scenario, where we've gone from 58% willingness to 72% willingness to respond. This is my final slide. I thought I'd simply give you a taste of some of the research that we're doing with some example publications. So there's a lot there on willingness to respond, public health workers, emergency medical services, hospital workers. We're doing quite a bit looking at the legal and ethical environment around public health preparedness. And of course, we're doing a lot in terms of psychological first aid and in other mental and behavioral health issues. Thank you very much.
The best tributes I heard about John's work and his translation of that science to the front lines was from one of the battalion chiefs here in Baltimore, who talked about having doc links there when they faced challenges that frankly they were afraid of. And firefighters are amazing. They're almost fearless, except when it comes to radiation and some of the threats that we have to deal with in public health. So our next speaker is going to talk about mental health. And just think of the earthquake. I have friends who work down live in Manhattan and work down in the financial district, and they had that little tremble. Now they're used to the subway, but when things began to tremble, they were immediately transformed back to the days of 9/11 and fear that something's happening. Here we go again. Here we go again. And that's just a little minor example. We've all heard of the tremendous impacts of Katrina, the public health workforce there, the responders there. I think we may have, before 9/11, truly underestimated the tremendous mental health impacts and the far-reaching mental health impacts. And our next speaker is going to talk about that. Dr. George Everly is an award-winning author and researcher. He holds appointments here as associate professor and in psychiatry at the School of Medicine, Psychology at Loyola University, and is an associate here at the School of Public Health. He's a member of the Johns Hopkins Public Health Preparedness Programs and executive director of Resiliency Science Institutes at the University of Maryland, Baltimore County. That is a research and training consortium. He served as an adjunct faculty of the Federal Emergency Management Agency and with the FBI at their academy in Quantico. He's authored and co-authored many books on mental health and the mental health aspects of disaster, including The Resilient Leader, The Resilient Child, Crisis Intervention, Disaster Mental Health, Pastoral Crisis Intervention. And I'd like you to welcome Dr. George Everly.
Good afternoon. This is where I talk to you and you talk back. Good afternoon. All right, thank you. It's an honor to be here. My job is to talk a little bit. I thank Dr. Links for the strategic perspective and how research is being applied. I'm going to take a slightly different tact. I'm going to talk about the tactical around 9/11. As Dr. Links mentioned, 9/11 changed a lot of lives. It certainly changed my life. My life took on a different perspective. But I don't want you to think that all of a sudden my career took a hard left or a hard right. It wasn't my first rodeo, so to speak, from the disaster mental health point of view. From 1993 to 2001, I served the Emir of Kuwait after the first Gulf War and had a lot of experience in terms of the mental health consequences of disasters, of terrorism, of weapons of mass destruction, in a way. Oklahoma City, I spent just about a year after the Mura building was attacked. But this one was different. New York City, I did not serve at the Pentagon, but I served at New York City, clearly changed my life. My first experience, the buildings came down on a Tuesday, the 11th, and I found myself there on September 15th and stayed for about 3 years commuting. But these were some of the images that I had remembered and worked with in terms of disasters, human-made and some were natural. When I first got to Kuwait, there was the world had changed very clearly. 700 oil wells, and that's from the physical side. I want you to think of the mental health consequences of having this as an environment and surviving this. But I also want you to look at these pictures and consider not just the physical, but the mental health aspects of what you're about to see. I took this picture at Ground Zero on Sunday evening after the Twin Towers came down. And in a way, it was a metaphor for me. There were about 3,000 people at Ground Zero, but you can only see really 3 here. But it serves as a metaphor for me because there was a vacancy. And there was a calm after such a disaster. I worked for a lot of different people, had a lot of different perspectives. My first job was working with the New York City Police Department's Early Intervention Unit. This is a crisis intervention team that was formed. But the union, New York City Union, also formulated its own crisis intervention team, and it was called PAPA. And we were housed at the Federal Reserve Building, which was only a few blocks from Ground Zero. And PAPA stood for Police Officers Providing Peer Assistance, meaning crisis intervention, peer support. I later worked with the New Jersey State Police, the Port Authority Police of New York and New Jersey, where I was specifically asked to work with the command staff of the World Trade Center, those who had obviously survived. I later worked with the University, UMD&J, medical and dental facilities in New Jersey, worked with the American Red Cross, and lastly the International Critical Incident Stress Foundation. I share this with you only to say that my perspective is multidimensional. A lot of different perspectives over a lot of different years. This is actually a crisis intervention team. This was the first time in North American history that I am aware where crisis interventionists, psychological crisis interventionists, were allowed in what is called the hot zone. Traditionally, psychological services were provided outside the hot zone perimeter. We tried that for several days. We had a wonderful facility at the Federal Reserve. We had 24-hour food and beverages and cots. We had a 24-hour hotline. And largely no one came. So if they won't come to us, we decided that we would come to them. But this changed everything. And you can see by the breathing, protective breathing apparatus on people's faces, it's probably hard to establish empathy and communicate with these devices, but that's what you did. One of the best things we did was to wear the shirts that you see. And I'm not the brightest guy on the porch. I wouldn't have thought of this in advance. But one of the things that we found was that strong people in crisis, about the last thing on their to-do list is to talk to a crisis interventionist, even though they may have the desire to do so. And that was one of the problems with coming to the Federal Reserve building that we had our facilities at. So when we went down to Ground Zero, we were just walking around. Someone later called it stealth mental health. And we would talk to people. We would just engage them. We'd say, hey, how's it going? I'm George. I'm from the Early Intervention Unit. And that was okay when you had to approach people. That's the most difficult type of engagement, though. It's better when they come to you. Well, these shirts, Papa, they were a magnet. On the front of the shirt was a emblem of a police badge, but on the back were the letters Papa. And people would come up to us and they say, "What does Papa stand for?" And we say, "Well, I'm so glad you asked. You want to chat for a little bit?" So, in a way, wearing the Papa shirts were it's kind of like trolling, I guess. But that ended up being one of our more effective intervention tools, at least beginning the engagement. You'll see a group of people at the lower right-hand corner of this slide. We certainly understand the need to provide psychological services for civilian survivors. One of the conundra was, do you actually dedicate resources to first responders and first receivers? Aren't they self-selected? Aren't they naturally resilient? Answer to both questions, yes. But everyone has a point where burnout and perhaps even vicarious traumatization becomes an issue. So one of the things I will suggest to you is that every disaster plan must have some aspect that is not only dedicated to the mental health of civilian survivors, but also first responders and first receivers. My first meeting was Sunday morning in the mayor's office, and the first question that was posed was, we've got a catchment area of 10.5 million people. What are the psychological casualties going to look like? And my response was cryptic off the top, better to be lucky than good, turned out to be pretty accurate. But I said we have two groups of people. We have the survivors, civilians. Their trajectory of mental health distress and recovery will look very different than that trajectory for the first responders. The most effective coping mechanism we have identified for first responders, believe it or not, is keeping busy. We were not concerned about the mental health of the first responders initially. Our first concern for them was, what happens when you close the site? What resources will be available then? For the civilians, a very, very different trajectory. And what you found is the spike in demand for mental health services was roughly November or so in 2001 for civilians, but it was about November of 2002 for the first responders. And here again you see one of the folks wearing the Papa shirt, just doing stealth mental health. Now, all of these individuals were New York City police officers, duly sworn law enforcement officers who had received special training in psychological crisis intervention, what we would ultimately call psychological first aid. What are some of the lessons learned? Well, you've got to put this into context psychologically. It does matter. We know that human-made disasters are more distressing than natural disasters. So you expect that. We know that terrorism is the most severe form of human-made disaster. So we need to understand just a little bit about terrorism. It's been said I'm a terrorism expert. I never took a course on it, but I worked in an environment where it was prevalent for almost 10 years. So one of the things we must understand is the goal of terrorism is not to kill or to destroy, it is to demoralize. Whether it does that directly or indirectly really doesn't matter. But it's all about psychology. My last address when I was leaving Kuwait to the Kuwaiti Parliament was that your country will never recover until there is a will to recover, and that's psychology. And I will say that to any community anywhere on earth. You can throw money at physical infrastructure, and that is helpful. And certainly you must provide basic needs. But whether a community that is struck by a crisis, by a disaster, ultimately thrives again is a function of the mental health aspects of that community. From a psychological and behavioral perspective, we understand that terrorism represents psychological warfare. It is nothing less. The goal is to break down the resistance and diminish the will of a population. We must understand that from a public health point of view. We must prepare for that. One of the projects that we also work on that John didn't mention was what we call the 3 R's. It is a model of resilience that we've developed here at the university. We call resistance, resilience, and recovery. And one of the issues in the standard definitions of resilience, which is typically to adapt to or rebound from adversity, we decided to break those 2 verbs out and develop a whole initiative around building what we call psychological immunity or resistance. And I will boldly say to you that I think that should be an aspect of public health planning and intervention as well. Public health issues, again, what do we do? What are we concerned with? Well, we are concerned about SURGE, the increased demand for mental health services. We are going to see increased demand in civilians and, yes, in first responders and first receivers. They will be different. Their needs will be slightly different, but you will see an increased demand in both. We are also concerned in providing adequate mental health surge capacity. And this is where we at Hopkins have been at variance from some other folks in the field. We certainly understand, I think universally, that mental health casualties, again, people that can't function as normal, can't function independently and adaptively, mental health casualties will always surpass physical casualties. So when you estimate surge, we are concerned about the mental health surge, not just the physical health surge. We understand very correctly, for example, studying, for example, the sarin gas attacks in Tokyo, that if you have 5,000 people showing up at hospitals, that roughly 80% of them will show no evidence or showed no evidence of sarin toxicity or exposure, but 80% of those people are concerned. They are fearful. Well, those 80%, that 4,000 people will shut down your hospitals and perhaps deprive those who require physical medical interventions, deprive them from receiving such. So this is all part of the big mental health picture from a public health perspective. It is interesting, if we reflect back in 2003, Borodori wrote, "The violence of the attacks against the Twin Towers and the Pentagon has revealed an abyss of terror that is going to haunt our existence and thinking for years and perhaps decades to come." I don't think that has happened. I think the word haunt is too strong. I think Borodori has underestimated the resilience of the human spirit. I will say it has created a new normal, and if you don't believe that, just try to fly somewhere. You have to plan in an extra hour or so, and it's always fun to take your belt off and your shoes off and things like that. I always now, for the first time in my life, when I go through a security line, I think that I dress thinking, now what can I take off quickly and put back on? And I've never had to think of that before. So just little things. What have we seen? Well, part of estimating surge is going back and taking a look at epidemiologic data. I will say to you that the data from the World Trade Center is less than clear. We clearly have contradictory data. But here are some trends. There was a meta-analysis that took a look at 284 reports of PTSD following disasters in general, published in peer-reviewed journals 1980 to 2007. The average range of acute PTSD appears to be 15 to 25%. PTSD and post-traumatic depression range somewhere between 10 and 25% from 9/11. Again, reports will vary. The natural trajectory of post-traumatic stress disorder, which I believe PTSD first codified in 1980 in the DSM-3, still is the most severe psychiatric disorder that affects otherwise healthy people. So it is important to pay attention to such things. The natural trajectory of PTSD is about 6 months, with about 50% of the cases resolving. The other cases do indeed linger. This paper just came out in Lancet, taking a look at the police officers. A 9-year cumulative incidence of depression was 7% PTSD was 9.3, and panic disorder was 8.4. Again, 9-year cumulative. In other rescue and recovery workers, cumulative incidence of depression was 27, PTSD 31, and panic disorder 21. The incidence of most disorders was highest in workers with greatest World Trade Center experience. And research has shown the more time you spend at ground zero, the greater the psychological morbidity. The closer civilians lived to ground zero, the greater the psychological morbidity. 9 years after the 9/11 World Trade Center attacks, rescue and recovery workers continue to have a substantial burden of mental health problems, despite their natural resilience. Again, going back to 2002, preparing for the psychological consequences of terrorism, this Institute of Medicine report said the nation's mental health, public health, medical systems currently are not able to meet the psychological demands that result from terrorism. I ask you a rhetorical question. Have things improved? My point of view, they've improved. Are we fully prepared? I don't think we are. I think we still have a long way to go, frankly. From an intervention point of view, have we any lessons learned, any things that we can take home and plan, put in our disaster plans? Well, some surprising things emerged in the last 10 years. Evidence suggests that crisis intervention is actually superior to multi-session psychotherapy. And I'm a psychologist by training. That was surprising to me. An integrated continuum of urgent psychological care is mandatory. The possibility of adverse reactions to psychotherapy, they do exist, but not crisis intervention, at least indicated by some of the research. Now, as a clinician, I think you can screw just about anything up, frankly. But what the research is pointing to is that there were more adverse reactions to psychotherapy after the World Trade Center than there were crisis interventions. Most people report that they cope by talking about their experiences. Isn't that interesting? Well, I don't find that surprising. If you ever had a problem, what do? You pick up a telephone, you call a friend. They don't do anything to change it, but you feel a little better. But one of the key things that came out is that we should not force people to talk about things if they don't want to. We used to think, well, you need to talk about this. Person says, no, I don't. Yes, you do. Well, no, I don't. Yes, you do. Well, no, I don't. Yes, you do. Well, why do you say that? I took a workshop once. No. People that want to talk, we should encourage that catharsis. It is healing for some, but we shouldn't coerce anybody. Mental health needs to be part of every disaster plan. Importing hordes of grief counselors into affected communities does not seem to be efficient nor effective. I just have this, I read in the newspaper something awful has happened in a community, and you'll have the tagline that says, and grief counselors were dispatched. I have this image of a caravan of Winnebagos with smiley face flags, and that scares me a little bit. However, mobilizing resources, especially indigenous resources, one of the things that we believe here at the school is that we should train people in a community to help themselves, at least be the first line of surveillance, to be the first line of psychological first aid, and bring in as needed external resources. But I think we are leading the nation in that perspective, that it is imperative to train first line personnel to do surveillance and first line intervention. Psychological first aid, I believe, should be taught to first responders and first receivers. It should be taught to all public health personnel. That person that picks up the phone, regardless of what their job title is, if somebody is calling into a public health agency, the person that picks up the phone becomes an interventionist. We have a responsibility to train them to do that intervention well, whether they understand it's an intervention or not. Mental health clinicians need to be specialized in their training. They need to receive specialized training in disaster mental health. You can go through a 9-year training program in clinical psychology and never once take a course in suicide intervention, never once take a course in disaster mental health. And I don't know about you, but that scares me. And one of the most important of the innovative interventions is what we call resilient leadership. We are now using leadership training to engender resilience in others. And at first-line supervisors, wherever they are. You think of a hospital. You want to change the culture of a hospital? You want to create a culture of resilience in a hospital? Train first-line supervisory nursing personnel. That culture will change. So those are some of the lessons that one person has learned. They may be at variance from others, but I thank you for the opportunity to be here today.
One of the things in 1999, well before the events of 9/11, I was part of a planning group and directed a committee advising CDC on preparedness, on the pharmaceutical and medical stockpile development, before the nation really, I think, took preparedness all that seriously. And the scenario that the intelligence folks were telling us about was almost unthinkable. Simultaneous attacks in 2 cities with 10,000 plus casualties. Think of the surge capacity. Think of your most recent visit to an ER and the challenge that we have in thinking about the kinds of needs that we have in a large-scale disaster. And our next speaker is a national leader in this kind of thinking. He's a professor and chair of our Department of Emergency Medicine here at Johns Hopkins. He directs the Johns Hopkins Office of Critical Event Preparedness and Response, or CPAR, which is our university-wide entity created to oversee the institution's endeavors in preparing for and responding to high-impact disasters, particularly from potential terrorist actions. He's also director of the Center for the Study of Preparedness and Catastrophic Event Response. In 2005, Dr. Kell and his team were awarded a grant from the Department of Homeland Security to lead a consortium studying how the nation can best prepare for and respond to potential large-scale incidents and disasters. This 5th Homeland Security Center for Excellence, formerly titled the Center for the Study of Preparedness and Catastrophic Event, PACER, looks at deterrence, prevention, preparedness, and response, including such things as risk assessment, decision-making, and infrastructure. Welcome, Dr. Kell.
Thank you very much. It's a pleasure to be here. Similar to Dr. Links, twice now in my career I have inadvertently profited from the misery and misfortune of many. Back in the 80s, I fell into research on an emerging infection called HIV. I did not intend to do research on that topic, but one thing led to another, and my career took off. I actually didn't believe very much until 9/11 in disaster methodology, disaster preparedness. It seemed like we sort of muddled through reasonably well, and even though I had a number of people in my department who were interested, I didn't consider it a very valid academic discipline. It just didn't seem something worthy of a major institution like ours to go into. And I have to say, 9/11 changed that for me to the point that, given the kind of issues that we faced, I myself found the tools that we needed tremendously wanting just to look at it from an institutional perspective. On 9/11, I was sitting in my office, and my secretary comes in around 9-something and says, a small plane crashed into the Twin Towers of New York, and I couldn't even think of why she bothered to come in my office to tell me something that trivial. And I thought, okay, so some guy fell asleep in his plane, or in a very miserable way wanted to commit suicide and take some others with him or her. And then she comes in a little bit later and says, a second plane just flew into the Twin Towers. And I thought, God, what's the chance of that? What a coincidence. Somebody else has fallen asleep at the wheel. And it really took me, I was so naive in a way, but it really took me a couple of seconds or longer to say, hey, wait a minute, this is like so improbable. Something really is up. And so, we have TVs in the department and so forth, so we turn on CNN and we see this amazing stuff, a lot of speculation. A lot of phone calls flew around, and I called the dean of my school, who convened a senior leadership group on what we were going to do. By that point, somewhere around 10 o'clock, we all met, and we knew it was a fairly major terrorist event of some type. We had no idea, only an hour or so into it, as to what our vulnerabilities were and whether Baltimore itself would come under attack, or whether there'd be like huge amount of casualties and our health system would have to go into some kind of a response mode. And we literally shut down the hospital in many ways. A lot of the operations were already going, and so we couldn't stop that. In the dehiscence part of all this, many days later, I realized how just tremendously unprepared an institution like ours was, even at the hospital level. And although there had been previous work done, civilian biodefense, for example, resided here. I think it started up in 1998 by D.A. Henderson and Terrell O'Toole. They were just looking at only bio threats. People weren't really looking at the type of things that we faced at 9/11. So today, in the few minutes that we have, I want to take you through a real kind of boots on the ground, how an institution like ours historically have come to the level where we at in terms of preparedness. So this is, in many ways, our real experience. If you look just generally, I'm just going to waltz through this as to who runs things. There are two ways to look at it. If there's like a major crisis, especially if it's a potential criminal element involved, as was the case in 9/11, then the FBI becomes the lead organization. Doesn't matter what kind of health care you have and all that other type of stuff. They just take control, and that's all there is to it. And the Attorney General is the chief law enforcing officer. It's only subsequent to that, once sort of the crime scene aspects are not that forefront, that you get into this consequent management area, and then FEMA comes in, which we saw during these kind of hurricanes. And there are an awful lot of players involved, and sometimes the boundary as to who controls what gets very, very fuzzy. Well, what does this have to do with us? We did not know at 9/11 who we were supposed to talk to, who we were supposed to get information, who we were supposed to obey, who was supposed to tell us what to do or what not to do or to stand by and whatnot. So we decided at that point to form an organization, which you heard today is called CPAR, the Johns Hopkins Office of Critical Event Preparedness and Response. And we thought of it in terms of the biggest possible umbrella that it could be. CPAR is an umbrella organization for all intents and purposes that represents the entirety of the Johns Hopkins institutions, university, health system, and so forth. And the purpose was to have a very unified response. We have so many experts in all of our different schools, and during 9/11, everybody was given all sorts of interviews, giving their opinions, and talking in behalf of each of our little mini parts. Actually, they're not so small, but each of the many entities, sometimes giving conflicting information and even conflicting advice. And we thought we ought to have one central repository that filters all that and speaks in behalf of the school. And then ultimately, we wanted to have fairly uniform plans all across the various institutes. So the Applied Physics Lab, which has a tremendous amount of expertise in systems engineering, and then with the university and the health system, we got together and formed what is CPAR. And as I mentioned, CPAR represents all the schools in the university, the Applied Physics Lab, parts of the entire health system, including this entity that you might know of Johns Hopkins Medicine. And we're pretty spread out, and as you know, we just recently acquired a hospital in Florida, and so now our reaches go all the way into another state. And we worked with state and federal agencies, the military, and we had this war analysis exercise to figure out exactly how CPAR ought to work and how it ought to be governed. And so we created a board, and as you can see, the board of directors of CPAR has the senior-most leadership in the institution. But we found that there were three areas of programmatic loci that we had. One is who actually runs this thing during a crisis, and who makes the decisions. The second is how do we get uniform preparedness and planning. And the third major area is to develop policy positions in behalf of the institution. I'm just going to show you some actual data from one of our books. This is a unified command module that because I don't know how much you know about the governance of Hopkins. The university, the medical school is part of the university, but the health system is not part of the university. APL is part of the university, sort of, but there are parts of APL that are so double, triple, quadruple secret that not everybody, in fact, almost nobody in the university has easy access to what APL does. And so we have this unusual situation where not one single person at Johns Hopkins Institution has the final say in anything. And so we formed this unified command concept that works by consensus. And let me just see if I can scroll down this thing and just give you a sense that virtually every school has its own incident command structure. Prior to this, the hospital had a sort of command structure. Our other hospitals didn't. Almost, essentially none of the university schools did. And now, pretty much every single school has a very detailed command structure, much of which actually came into play during this last hurricane as a means of what to do and how to make decisions. And the details of what each of these positions entails. In the past it was, hey, why don't you be the disaster control physician? And no one would actually have any idea what that is. Or why don't you be the disaster control administrator? And there'd be a little bit of verbiage as to what that meant. Essentially you're answering phones and so forth. Let me just maybe talk instead, not following the slides per se, but about the kinds of things that we do. So I just showed you what we do on the preparedness end, and we have fairly uniform policies. Some of the big issues that we had faced, our very first one was on smallpox. You remember in late 2002, George W. Bush came out with a pronouncement, or his administration did, that smallpox is a really big issue, and he wanted to develop a vaccination plan for the entire country, starting with first responders. And without getting into politics of it, as you remember, many of the states did not want to play. Many hospital systems did not want to play. Rather than having this dictated to us by the state, we partnered with University of Maryland and the State Department of Public Health, and we sat down in a smoke-filled back room, metaphorically, and ironed out the conditions under which Johns Hopkins would engage. And we ironed out a policy for the state that was suitable for us and the state, and we're the only state where all 52 acute care hospitals were willing to play. Later on, we went into Iraq, found no weapons of mass destruction, and something like 17 individuals in our entire entity were vaccinated. Another big issue had to do with avian flu. I don't know how many of you remember that scare. Each of the schools had a set of different policies on convocation and who could come and who could go and so forth. And we sat everybody down and we came out with a uniform set of policies and applied them to absolutely every school, so people weren't dealing with a differential set of issues. Most recently, we dealt with the H1N1 crisis and how we could have a uniform response, and this truly affected the entire entity. We were initially allotted 1,000 vaccines for about a population that we were responsible for, not counting patients, of 42,000. Traditionally, we would vaccinate about 25,000 employees, students, and so forth. And we had to come up with a very complicated schemata that involved the distribution of these scarce aliquots across every one of our many, many entities, including the health system and the university, and make sure that everybody got their fair share of what they fundamentally needed. That took just a tremendous amount of work and a tremendous amount of angst. But in the end, because it was applied fairly and uniformly, we were able to do it. Most recently, and this is going to affect some of you, we worked on coming up with a policy framework for how to have a mandatory seasonal influenza vaccine program at Johns Hopkins. Those of you who are likely to set foot in some capacity or other in one of our clinical settings may only be able to do so if you adhere to the policy and get vaccinated. Otherwise, if you're in any situation where you might come in close contact with patients, then you won't be able to go into those areas, and you may not even be able to enter the hospital. And this policy applies to everybody at all of the entities, so the framework has to be adhered to, although there might be some very, very minor nuances. A couple of other things. We're not just insular. We've tremendously integrated with the state. We have memoranda of understanding with a huge number of the other city hospitals, with the state public health department, with the VA and so forth, so that we will be able to share resources when we need to, should push come to shove. A couple of other things. We've also formed medical teams. You remember when Katrina occurred, all sorts of medical voyeurs went to Katrina. They got on a bus, they got in their vans, and off they went, hoping that they could do something useful. Essentially, they all got in the way and took up scarce resources that were actually needed for the people who needed the help the most. Same kind of thing happened in Haiti. During Katrina, we formed a medical response team. We had like 600 volunteers, and we whittled that down to an entire hospital system of 125. And we deployed a good number of those on an EMAC between our state and Louisiana, to a location where they could actually be useful. And we stayed there for about 6 weeks, not providing emergency care so much as basic medical care, urgent care type of stuff, chronic care, continuity of care, because people didn't have ostomy bags, they weren't getting their insulin, they weren't getting their mental health drugs, and so forth. That program continues, and we have volunteers within our so-called Johns Hopkins Go team throughout the institution, so it's not only a medical school or a hospital response. We also recently led the development of the state DMAT team. Many of you know disaster medical assistant teams. Maryland did not have one. We really wish that we would have one. The governor agreed. This is a state asset, but Hopkins led the way, and I don't know if any of you are on the team, but half the members of the team, including the commander, is from Hopkins. So these are some of the types of things that CPAR is engaged in. It's a fairly mature organization at this point, and we learned a lot as we went along. We've done a lot of vulnerability assessment, and the planning and preparedness that each entity has done is along a continual framework that looks at what each of our schools, and it's slightly different for each school, ends up having to deal with. I also had like some really, really fabulous slides of the research that CPAR is engaged in. CPAR was originally meant as a response and planning organization, but we found ourselves having to do research because we didn't know the answers, and the answers weren't out there. So we actually have a very robust research program, and when I get a better and newer computer, maybe you could invite me back and I could show some of that. I'm gonna stop there, and many apologies, I have to say. And see, when did computers? I got my first computer in 1984. I don't ever recall one dying on me right in the middle of a talk. And I'm usually pretty good at resuscitation. Thank you.
Thank you, Dr. Kellen. You are amazingly resilient, though, without the audiovisual. So we now have some time for questions. Both our attendees here in the auditorium, as well as those folks online. I just want to remind those folks online that you can send a question in through Twitter with the hashtag #JHSPH911. So questions from the audience. I'd like to start first with a cultural question. Dr. Kellen, you kind of showed us all the agencies that were involved. And I recall vividly being part of a CDC committee that was supposedly going to be briefed by the FBI on events at 9/11 and then with anthrax. And then we found out the public health community, the medical community, really didn't have the kind of clearance the FBI was used to, so it was a very short briefing. And one of the tremendous attributes of CPAR has been getting people together. I wonder if you could comment on that a little bit.
Yeah, certainly at the regional and federal level, there is and remains great conflict and great trouble communicating across the different disciplines. The culture of the fire department is different than the police department, is significantly different than the public health department, and is somewhat different than the medical response aspects. So they still don't play well in the same box. One of the great things, truly great things about this institution is how well this institution plays for this type of thing. Two things we do well without looking at silos. One is research, and the other is this type of planning. The value of having CPAR at such a elevated level is that when we have an issue like H1N1 or mandatory flu vaccine or smallpox, and we have this speak with a unified voice, CPAR is able to convene just about everybody and anybody to come to a meeting and deliberate for however long it takes, for however many meetings it takes, and is able to have the senior-most leadership and experts in the room so that we can iron out these types of things. So I don't know what that will work in every institution, but because of the leadership culture at the university, at the schools, particularly in this campus, it really works very well.
And I want to commend you on the earthquake and the hurricane recently too, where there was a tremendous flow of information for all of us, I think, and I'm sure there was a major role played in that. So questions from the audience or from the internet. Natalie, do we have a question?
This question is from Twitter. How are innovations in mobile and communications technology applied in public health preparedness response today versus 10 years ago?
So communications is vital in preparedness and response in a number of ways. The question, I think, really asks about communications during response. I'll start there. There's a lot of research going on right now in the use of mobile phones and other mobile communication devices in terms of surveillance and reporting. So you can actually track cell phone usage and get an idea of hotspots in terms of the need for acute response. You can also use cell phones, of course, intentionally in terms of reporting in from the field. We're interested in the use of communication in its broadest sense, pre-event, to better prepare jurisdictions for events. And just as an example, George mentioned building pre-event resistance or psychological immunization. The way you would build that is through a communication campaign. So the use of mobile devices, I think, has a big role to play during the event, but the role of communication in its broadest sense, I think, has an even bigger role to play at all phases of an event, pre-event, during the event, and post-event.
Yeah. The question really has sort of two responses. One is the technical response. Has the equipment gotten better? Do the different agencies, are they able to crosstalk and so forth? And much of the money for appropriate crosstalk never really materialized. The second is in the area that Dr. Links mentioned, where there's research going on in this very school, which is how do you deliver content? How do you keep it clean? How much content do you give under what type of circumstances? And what you alluded to is from fairly hard-learned lessons over the last 7-8 years about trying to streamline the message to the right audience during the hurricanes.
Right. And it's interesting to speculate how things may have been different if we had the technology we now have for during the days of 9/11. The 10 years have changed, just from cell phone to incredible video. Other questions? Yes, in the back.
My question is mostly about mental health, and moreover, obviously there's a very clear period when it's definitely a need post a natural disaster or a terrorist attack, etc. But my question is more about how do you know when disaster mental health is no longer necessary? I mean, especially like you talked about, often it's better when they come to you rather than you seeking them. So how do you kind of, I guess, wrap your head around when you don't think you're needed anymore versus when, it's just kind of like a lull and that kind of thing?
Well, it's a great question because you're talking about not just clinical issues, but utilization of resources. From my point of view, disaster mental health resources goal should be to make your job obsolete. What you want to do from a screening and assessment triage point of view, as early as possible you identify those people who can't function. So our criterion is functionality. We identify those people who can't function from a psychological perspective. They can't discharge their responsibilities, whatever they may be, child care, etc. Our goals are very simple. Stabilization. If psychological and behavioral functions are deteriorating, the first thing you do is stabilize, i.e. keep things from getting worse. The second thing, once you've stabilized, is to say, can we mitigate the acute distress? You switch to a different set of resources or interventions to mitigate acute distress. But the most important thing, and we emphasize this in our rapid psychological first aid model, it's handing people off. What we want to do is, once we've mitigated the acute distress, hopefully restore some level of functionality with the individual. Or even if you haven't, identify the appropriate resources so that you can transition this person. Is it back to family and friends? Is it to occupational resources? Is it community psychological resources? Is it an acute care psychiatric facility? Those kind of determinations have to be made. But the most important thing, I think, that you need, to borrow your term, get your head around, is that disaster mental health is acute intervention. It is not treatment. It is not diagnosis. In fact, those inclinations probably serve to work against effectiveness in the field.
I had a kind of a general question. Is this working? I don't know. That sort of has to do with this idea that my impression of it since 9/11 and maybe even before is that in terms of the people setting the policy agenda, in terms of providing funding from a federal level, especially with lawmakers, there's a lack of sustainability or a lack of an awareness of having funding and focus in a preparedness context. Like, it seems like money gets thrown at you right after a disaster, right after an incident, and then it gets taken away pretty quickly. You have to spend it. People spend it on things, and sometimes they spend it on training, but there isn't an idea that you have to keep doing that and that you have to have planning. And I'm wondering from your end, and it affects everything that you're talking about, and I'm just wondering from your end how you change that conversation, how you get people to realize that it's not just during a disaster, immediately thereafter, that it should be the focus.
So we certainly experience the phenomenon you're talking about. And for us the phenomenon is really sort of the human attention span phenomenon and what's urgent today as opposed to what's important over the long term. And in a paradoxical way, as new disasters come along, it somewhat mitigates that phenomenon, which is a terrible thing amongst all the terrible things we're talking about this afternoon. But there's another aspect that you touched upon that I'd like to amplify. There are a lot of times where what we do in terms of disaster medicine and public health preparedness, just broadly in terms of disaster health, are really dual use. So there's a lot of things we do that actually help routine public health practice, that help routine healthcare delivery. And the trouble is that sometimes the funding has such a specific earmark that even though you could get dual use out of the intervention, you're prohibited from getting dual use out of the intervention. That's my greatest frustration. And in fact, back to this model of efficacy and efficiency, it seems to me that what we should be striving for is preparedness interventions that actually have a benefit every day in terms of routine public health and routine healthcare delivery. And in fact, a lot of the stuff we do does. That's also a way in which we try to position it. One of our challenges here at Hopkins actually is to get the leadership amongst all the competition for their money to spend money on preparedness activities. And part of the way we address that is through highlighting the dual use. Think about this school. So if we had a pandemic, how are we going to keep delivering academic programs? Well, at this school, we're going to do it through distance ed. And we were able to do it through distance ed because there was a recognition of the positive impact of distance ed on a daily routine functioning basis. So imagine if we were trying to sell distance ed as a pan-flu intervention, period, versus selling distance ed as something that enhances the operation of the school in the absence of any crisis.
I have a question for the whole panel. We've talked about various aspects of preparedness, and we've covered the terrain pretty well. We've even talked about funding and the crisis response nature of our funding mechanisms. But I'd like to ask you, kind of in a figurative way, what keeps you up at night? And what are the gaps that we should be thinking about as researchers, as clinicians, as students to be prepared for the future? Because we always tend to prepare for the past threats. And it's always a challenge to think forward. So what keeps you up at night? And would you care to respond to that in terms of how we can prepare our students, our researchers to be responsive?
I happen to be up most nights, so
that's true.
Doesn't necessarily keep me up. A couple of things. One is that I might not be able to be found when I really need to be found. During the earthquake, I was off camping. I actually felt the earthquake, but I wasn't near my phone, and I missed actually quite a few phone calls. Unfortunately, there wasn't any really big deal, but in another setting, it could have been. Now we have a resilient, redundant system, so it doesn't really matter. But the second for me is and this is very personal, is the potential conflict between my formal role in the institution and my role in my family and their protection and worrying about them. And I have to say, I haven't totally figured out, am I in such a paramilitary mode, because I really believe that if you're in the incident command, you're a paramilitary mode, that my family actually comes second. Because I don't really come from a military tradition, so I don't have that as a background, and yet I understand it, that if I'm going to have this kind of senior leadership position, that I have to be present, able, no matter what's going on with my family. And that's a real disconnect for me, and one that I don't really face.
Great answer, and one that so many of us face. Thank you. George?
I guess the thing that keeps me up is that when I think about threats from a psychological perspective, again, I think about the distinction between natural disasters and human-made disasters. And then I think about, as I mentioned earlier, the most severe form of human-made disaster, which is terrorism. And I think that we are vulnerable. I will agree to some degree with the Institute of Medicine report. We are not prepared as well as we could be or should be. And if somebody really wanted to devastate our economy, the way to do it is through psychological terrorism. And frankly, the technologies that have been used so far haven't even scratched the surface in terms of their potential for disruption and destruction. So that concerns me.
Thank you.
So what keeps me up at night is the siloing of emergency management from other risks. And I think we focus so much on the sources of threats without enough recognition that the targets of threats are pretty much the same, whether we're talking about, for example, a pandemic or an economic downturn. So if you think in terms of targets rather than sources of threats, people, infrastructure, finances, etc., we would begin to be more harmonized in our approaches to risk management. I think it goes back to the earlier question about the attention paid to crises. Here at the university, there's now been a recognition of that, and there's actually a new institutional risk management program that's been launched. I'm happy to be facilitating that effort on behalf of CPAR, and we're harmonizing across every possible sort of risk the university faces, including but far from limited to emergencies, disasters, and crises in the narrower sense of the word. And that, I think, is the way to bring appropriate attention, activity, and resources to bear on problems. It goes back to this notion of dual use, but it becomes triple, quadruple use once you start thinking about, I have to, for example, protect finances, wherever the threat to finances comes from. You end up building a much more robust preparedness and response system across a variety of risks.
Thank you. Final questions from the audience? Well, I want to conclude by saying that I sleep like a log because leaders like you are thinking about these things, are leading our institutions, advising our government, because students like you are learning and pushing the envelope so that we can be better prepared and thinking about the challenges of communication and resources as well as the scientific translational challenges. And the public health community in general is a tremendous community that can work together to overcome these kinds of things. So I want to thank you all for being here today, for joining us on the internet, and especially thank our speakers, and have a good day.